too much medicine, right? Then we have three speakers who will be addressing you today. Before I begin on the symposium itself, and I know how many of you are members of the SLMA. Can I have a show of hands? Those of you who are not already members of the SLMA, I warmly welcome you to become members of the SLMA, because you will be a member of the oldest of all medical and professional associations of Asia and Australasia, and there are a lot of advantages when you become a member of the SLMA. Right? You will be able to receive our monthly newsletter free of charge, which contains a lot of material of all the work done for the month, and also it's good for your CPD knowledge. Furthermore, you will get the e-bulletin free of charge, and you will be eligible to receive travel grants given by the SLMA, and also you'll be able to showcase your research that you do in the annual academic sessions, which will be held in July this year. And apart from that, you can also take part in other social activities, in the cricket matches, in the netball tournament, and also can come to come to the SLMA dance. So those who are not already members, I have application forms here. So I do hope you will take these application forms and become members before you leave the room, right? So please do become members of the SLMA. We have around 4,000. I'm hoping to bring it up to 4,500 before we go over. So please, those of you who want application forms, please join. My co-chair is Dr. Sarat Gamini, and Sarat Gamini will now introduce the speakers.
Good afternoon, ladies and gentlemen. Very important topic which is being discussed by all the patients. I don't know how frequently discussed by the doctors themselves, whether with all the equipment available to us, with all the facilities, whether we are overdiagnosing conditions, and with all the new drugs available to us, whether we are over-treating as well. So to discuss that, we have to open the Yukas Kumar Mendis to discuss why bother about this topic at all. Kumar Mendis. So you can wait on for 1 or 2 minutes. Right. And Professor Kumar Mendis has been interested in this topic all the time. He happens to be the professor of family medicine at the Colombo Medical School. Let me go before change. Oh. Good afternoon, and thank you very much for being here. When we started this thinking about this session, I was not sure whether we could get 3 or 4 speakers to speak on this topic. And I persuaded Agnes, who is the editor, and he said we will try to get at least 2 more. But I am very happy to say that all the people who we approached did not have any doubts, and some were telling how much time would you give us to speak on. That was the question. So, I think, madam, we need an overhaul of the technology in the most, So, right. the topic, too much overdiagnosis. Most of our doctors want to do good. We have been discussing this just a few minutes ago. Nobody really means to do harm. So, but few would agree with the famous writer Ivan Illich that medical establishment has come towards a threat to healthcare. I don't think we have gone that far. But we may agree with one of the foremost health economists, Alan Etowan, that increasing medical inputs will at some stage become counterproductive and produce more harm than good. I don't think anybody will have much problems with that statement. So, my question is, have we got into that tipping point where we have to decide whether we are doing good or harm, or is the balance tilting towards harm? Very simple definition of overdiagnosis. Overdiagnosis occurs when individuals are diagnosed with conditions that will never cause symptoms or death. There are many definitions. This is a very simple definition. So, some of the other names that we give are over-medicalization and subsequent over-treatment, some call diagnosis creep, shifting thresholds. This is a very nice thing that has been happening. Shifting the threshold of blood pressure, diabetes, you name it, it is happening now. And this is mongering. Let me give one example of shifting thresholds. Everybody will know this. What happened in 2017 when they tweak the blood pressure. The numbers are very, very clear. According to the new guidelines in 2017 of the American Heart Association, the number of people labeled as having hypertension will increase in the US by 26% and in China 45%. So 75 million in the US and 55.3 million in China would be newly recommended for treatment with hypertensive drugs. Right. So, and I don't have the time to play this very nice video by Professor Alan Francis, who was the DSM-4 chairperson. And when he narrates the story of what happened in DSM-3 to 5, how people created psychiatric illnesses, and by the time some of the people slept, they did not have any psychiatric illness. By the time they woke up, about 1 million people had a psychiatric problem. I mean, the man himself says he's the chairperson of DSM-4. And he didn't get the chairperson to act as 5, but he was in the committee because he was dead against meddling about with thresholds. And to the children, what we are doing. There's a nice article in Pediatrics about, when we were disruptive, we got a spanking. But now you are given a drug, right? So, this is again not from third or fourth class journals, it is a journal of pediatrics. They identify 9 conditions where we may be doing harm. However, not all agree that overdiagnosis is happening, and about 10% of the people argue. And among the main journals who are arguing that, no, don't worry, it's the New England Journal of Medicine. Right? And they question the less is more crusade by JAMA. Are we over-medicalizing or over-simplifying? I mean, that's a fair question. So the BMJ has replied very nicely. And this word was not coined 1 or 2 years ago. It has been there for the last 50 years, the overdiagnosis. Starting with screening, as you will get a very good dose of, I think, low dose radiation on screening by Dr. So I'm not going to speak about that much. 2002, the BMJ started this campaign. They questioned, was it too much medicine? But in 2014, it is too much medicine. There's no problem. They have gone on the campaign, and JAMA joined in 2010. And there's a very nice, even a person who is driving the car can hear this kind of audio, 10 minutes audio on the breast cancer surgery, which clearly says less is more. The book that created a very, very wide opinion from the journalists, the patients, and the doctors are this overdiagnosis making people sick in pursuit of health. This was a worldwide bestseller. And now, every year from 2012, preventing overdiagnosis, there's a world conference. And the last conference, the coming conference will be in Sydney, Australia. And at least 500 plus of academics and doctors are supposed to. Normally, the last statistics of the people who went for the 2018 was 500. So, why bother? This came 1 month ago from the Cochrane. Now, the GPs are very fond of general health checks, so as the package deals from all private sector hospitals. Very clearly says, I will read it because it is very, very infrequent. Their Cochrane reviews give a very clear, they will always tell you have to do more research. Here, no 2 words. Key message, the systematic review was done. The aim of this Cochrane review was to find out general health checks, whether it reduces illness and deaths. So the conclusion was systematic effects of health checks are unlikely to be beneficial and may lead to unnecessary test and treatment. This came out last month. Very clear. And there's a nice thing that the NHS is doing now. This is the top part of a slide. Interventions which should not be routinely commissioned or performed. And they give a very nice bit of evidence, and 95% snoring surgery, dilatation and curettage for increased menstrual bleeding, knee arthroscopy and spinal injections. Very clear. Why bother? Again, the cost. These are 4 billion estimated in US dollars on breast cancer overdiagnosis in the US. Now, about the suffering. I told you why we are concerned, because the evidence is there. The cost is prohibitive. And what about the suffering? Right. This is again taken from the Lancet 2017. If you take 1,000 women and screen them for 20 years, you will prevent 4 deaths from breast cancer, but 8 women will still die. This is not suffering, but next. Now this is suffering. During that period, 1,000 women, 412 women will experience a false positive result. And 67 women will have a biopsy, and 345 some other extra test. So the massive psychological, physical suffering that goes on. This is very, very methodical breast screening that was taken in Canada, US and UK, the summary statistics. So again, you will see it is a problem for the West, not in the East now. There's a very nice article in the BMJ again by the Indian editor, why medicine is not a problem only in the rich countries. Mapping the drivers, why is it going on and on and on? Why is it happening? There's a very nice article written by one of a Sri Lankan doctor now in Australia about the drivers of overdiagnosis. Very briefly, it is patients and public and goes on to cultural things. And she very clearly defines the drivers, why it is going on, and gives some very nice things you can do about it. Not only talk about it, something that can be done. So what can be done? Choosing wisely. I think some of you may have already heard about this initiative in the US by 70 specialist societies. They have come together and at one website they have put all their college of physicians or pediatricians, everybody who has something to say, not to do, has provided this choosing wisely. And from the US, they have come to the UK and there is choosing wisely UK. All colleges and societies in one website. Can I just suggest that the SLMA, madam, take some initiative in getting the colleges together and the ministry. And if we have some very valid recommendation, put it on the single website and maybe we can call it Choosing Wisely Sri Lanka. We did this about 1 month ago. The ministry called a group of experts, surgeons, radiologists, and discussed about the current breast cancer screening guidelines. And we had a very nice discussion about 2 or 3 days and came out with the guidelines. When I went to access the website this morning, this is the message that I get. It is not available, website is suspended for some reason, right? So there's a very nice initiative, right? And you can get all this information and more in the website. You can just go there and you can read anything. Everything is reference, articles can be downloaded, everything. And thank you. I think I have a few minutes, but let the others, some of the doctors have very nice presentations, not like this one, really clinical stuff. It may listen to the next speaker.
Thank you, Professor Kumar, for that very interesting and enlightening presentation. We'll next move on to the next speaker, Professor A. Padmeswaran. He will speak on screening for disease, preventing harm or harming the healthy. Professor Padmeswaran is Professor of Public Health at the University of California. And over to you, Professor Padmeswaran. And he also has been the editor of the Ceylon Medical Journal for about 10 years now. For about 10 years.
3 years.
3 years, yes.
And I was also your first house officer.
Yes, and he was also my first house officer in Karapidya. The time the hospital was opened, Karapidya. That was in the early 1980s.
Good afternoon, ladies and gentlemen. Thank you, madam, and thank you, Kumar, for getting me into this. Uh, The title is nothing original. I saw an article in the PLOS Medicine about 5-6 years ago about screening for chronic kidney disease, preventing harm or harming the healthy, and I am interested in screening, so I thought I will use this title whenever I get a chance. So I have got my chance. I mean, all of us are keen on screening because we believe, right? It's actually a belief, not really a truth as such. We believe that reduces morbidity and mortality from the diseases because we find them early among people screened. And the detection and appropriate treatment leads to better outcome. That is our belief, and based on that belief, we think we should do more and more screening. And there are possible there are benefits of screening in the sense screening and early detection could improve prognosis, reduce morbidity, and both these together may be improved quality of life. And there is this strong belief that it reduces resources needed for treatment. Yes, for individual cases, if you detect early and treat them early, it reduces the resources needed. But if you look at the supermarket analogy, you are going to treat a large number of people, small benefits, large number of people. So then if you calculate the cost, it may not be a real cost benefit in terms of cost, right? Then the last one is a good one. That's because reassurance from a correct negative test. This is people who don't know that what breast cancer is, or who don't know what prostate cancer is, and they are living happily. And we make them worried by talking to them about breast cancer and prostate cancer. We do the test and then say, now you don't have to worry. Like, I mean, this is really, I don't know why people get it from us, but you get. But I mean, screening is associated with increased survival time and reduced case fatality. This is what the main selling point of screening. Right? And before we can say that this is really valid, we'll have to make sure that is it really real or is it some sort of bias? And there are two types of bias that can lead to this increased survival time and reduced case fatality. One is called the lead time bias and the other one is called the length bias. I will just try to demonstrate what these are. Right. So if you say that there is a progression of any disease, right, starts with biological onset, and after some time it is detectable by a screening test. And even after some more time, there may be symptoms, and people will come to doctors, and we can detect them. And death, or we can delay death by screening and appropriate treatment. That's what we believe, in the sense that there will be a longer gap between diagnosis and death. This longer gap between diagnosis and death, the time between diagnosis and death, could be due to actually delayed death. I'm not talking about screening here. I'm talking about actually improved therapeutic measures. Say if you are talking about some leukemias and stuff like that, we know during our lifetime there is increased survival, improved survival, right? So that is really possible. But also, you can have increased survival not because we have done anything to the expiry date, but by increasing or earlier detection and labeling them early. Because we have detected the case early, we have no influence on survival, but it looks like there is longer survival because they have been labeled for a longer period of time. But what we believe is the third option, earlier diagnosis leads to delayed death. And it's not, even the fourth possibility is real, in the sense earlier diagnosis and a slightly earlier death, right? So they are still labeled for a longer period of time, and it looks as if there is increased survival. So if you look at this same graphic again, so instead of somebody being labeled at 50 years and dying at 60, I mean, I made this slide about 5-6 years ago before I reached 60. If I had make it again, I will shift these ages a bit, right? So if you are labeled at 50 and die at 60, right? If you are labeled a little bit earlier, you just, even if there is no survival benefit, it looks as if you have lived longer with the disease, right? So it is the responsibility of the people who are promoting screening to show that it is not this artifact, there is really real benefit, right? The length bias is, say if you think of a malignancy which has two different types. One is a very aggressive type and the other one is a very, not, you can't say a malignancy, benign, a low grade malignancy, right? An aggressive and a low grade one. So we'll just imagine that each of these kill people at 60 years of age, right? One takes 5 years to grow, the other one takes 25 years to grow. Right? The aggressive one is in 5 years it kills. The other one, so it starts at 55 and kills. The other one starts at 35 and kills. And each of these have different periods of disease-free but detectable by screening test. Right? So for the aggressive one, this detectable period is only 1 year. Before symptoms appear, there is 1 year of screen possible period. For the low grade one, this period is 5 years. Right? So if we have a screening program that goes every 5 years, it's definitely more likely to catch a lot of type 2 diseases than type 1 diseases, because only 20% of type 1 diseases can be caught if you have a 5-yearly screening cycle. But 100% of low grade disease can be caught if you have a 5-yearly screening cycle. So based on this, if you don't have to do a lot of mathematics or statistics to realize this, screen detected will have definitely a better prognosis than clinically presenting cases. Right? So that is the other possibility because of this length bias. Now these can be seen in prostate cancer data very clearly in almost all countries. I just looked at the data from Finland. Right? The y-axis on the left is standardized mortality ratio. This is a very simple metric where we look at, because prostate cancer patients are going to be older than other people, so you can't just look at their mortality rate. You have to look at their mortality rate in comparison to similar aged people. Right? So the SMR gives you how bad is their mortality compared to people of that particular age. And if it is the same as that age, it should be an SMR of 1. Anything more than SMR of 1 indicates higher mortality. So what it shows is the blue line at the top is overall for all cases of prostate cancer, what is the SMR. And in the 1980s or late 80s, it was more than 2, and it has come down to about 1.4 or even less than that, 1.3 by the end of, in that period 2005-2009. If you look at localized prostate cancer, the rates for SMR for localized prostate cancer, it's starting somewhere around 1.4, 1.5. And the interesting thing is it is coming to less than 1 towards the end of this epidemic of prostate cancer. That is what is shown in the green line, right? That is with the DSA screening, the number of cases have gone up, right? So now I said the SMR of 1 means your mortality is similar to people at the average mortality. So does it mean that it is good to have early localized prostate cancer because it reduces your mortality? No, it is not. what it shows is that a common phenomenon which was made into focus by Julian Tudor Hart about the inverse care law. People who really don't need it will access care. Right? So all this prostate screening is being done by the really healthy people who don't need it. Right? So their mortality rate is less than the average mortality rate, and that is what is being shown by this red line going below the SMR of 1. Right? So this is in Finland, but I am sure if we have the data in Sri Lanka, we can do it for us also. So about 50, 60 years ago, this was developed by two researchers, Wilson and Jung, about prerequisites for successful screening. And it's a very simple, common sense things they have said what should be there for successful screening. The condition should be an important health problem. There should be an accepted treatment for patients with the disease. So we should know exactly who a patient is and how to treat these people. And facilities for treatment and diagnosis should be available, not in your teaching hospital, but for everybody. Otherwise, there is an equity problem also. Right? And there should be a recognized test. There should be a suitable test or examination. Usually, nowadays, there is a suitable test looking for a disease and we find the disease. Right? And the natural history of the condition should be adequately understood. I mean, if we don't know the condition adequately, we shouldn't start screening. And the ninth one is very important. The cost should be economically balanced in relation to possible expenditure on medical care as a whole. Right? I mean, there is nothing free, nothing cheap. If you spend it on screening, you are going to not spend it on something else. This is not only true for a developing or a middle income country like ours. Even the richest countries can't have everything. So if they spend on something, they have to cut it down from something else. So we will have to decide whether this is what we want to spend our resources. So what are these possible adverse effects associated with screening? Long period of morbidity, right? Because we have labeled them and they are going to be morbid. And diagnosis of pseudo disease and overtreatment. I mean, prostate cancer, which wouldn't have come out, which wouldn't have caused any problems to the patient, which would not have killed the patient, is now diagnosed and they know that they had it. And then this false reassurance from a false negative test. If you are a clinician, you will know that there are people who have had a, say, pap smear or something negative, and then even when they develop symptoms, they don't go to the doctor soon enough because they have recently had a negative test, right? And so that is a real problem. And anxiety and morbidity associated with the false positive test is real. I mean, we can always say, no, we have done so many other tests and now it's all negative. That was a false positive. I mean, the concept of false positive is very difficult. People will think there was something, a small thing was wrong, but vast majority is right. That is what they will think, right? So it's not easy to get rid of this anxiety associated with the false positive test. And diverting resources is the other issue. So what we usually do is we usually say burden warrants a program. Is there a test? Yes, there is a test. Are there effective treatment? Yes, all this we can say yes. But the last one is very important. Has the effectiveness been demonstrated? What I mean by effectiveness being demonstrated is not the effectiveness of the test or the effectiveness of the treatment, effectiveness of the program as a whole. Right? When you screen a group of individuals or community, do you show decreased morbidity, mortality in that community? That is what is meant by this effectiveness being demonstrated. The last one I want to show is a picture I took at a government hospital in Sri Lanka just 2 months ago. The poster is in the patient's waiting area and the whiteboard is inside the consultation area. Right? And the poster is asking people to find whether they have got osteoporosis or not. And the OS drugs Even my 40-year-old pharmacologist tells me that some of these are important drugs. There are things like thyroxine, there is HCT, and a lot of things, your asthma drugs, none of this is available. And in small letters, alendronate is also there, that is not available in this hospital. And we are screening them for osteoporosis. Thank you.
Thank you, Professor Padmaswaran. Let me remind each speaker will speak for 15 minutes. And next it will be Dr. Kanta Samaravikrama, the consultant radiologist, who will talk to us on mammography for breast cancer screening, the good, the bad, and the ugly.
Slideshow ಗೆದ್ದೆ. Slideshow. Making them. Good morning. I think I must thank Dr. Kumar Mendis and also Dr. Indra Amarasinghe for inviting me. Actually, my invitation came through Dr. Indra Amarasinghe, who is the consultant oncologist, as an oncosurgeon. So, on Too Much Medicine, my topic is mammography screening for breast cancer. Whether it's good, bad, or whether there's anything ugly. That's how Dr. Kumar Mendis wanted me to speak on. Simply now, actually I'm not going to talk too much on statistics and things, but the practical situation of practical setup of mammography screening. So simply, what's a mammogram? Simply it's a breast X-ray image using soft low kV X-rays. You know, in a chest X-ray we use about 120 kV, these are 20 to 30 kilowatts. And now we have developed, technically our mammography field has developed and we get different types of mammograms. So we are all used to film screen system of mammogram, that is conventional analog type. Those mammograms of course now getting replaced by digital mammograms almost everywhere. Digital mammogram has a very significantly high resolution and you get a very clear picture. Actually, all these things are important if you are planning a screening mammogram project. And we have gone beyond that now. We get the tomosynthesis. That is called, we can add to digital mammogram a thing called tomosynthesis, and which has a very high resolution and which gives us very much more details. What is tomosynthesis? Actually, it gives us a 3D image of the breast. Oh, the video is not playing. There's a video, it's not playing, I don't know. Small clip. So anyway, what we are doing is we take multiple projections over the breast in an arc fashion and reconstruct to give us a 3D image. No. Araki video again. It's okay, right? Okay. So now we have advanced very much, and with actually as we go on we will see the difference between the conventional mammogram and the digital mammogram plus or minus tomosynthesis. And there are clinically two types of mammograms. One is diagnostic mammogram. Diagnostic mammogram is done on a clinically positive patient to analyze further what is the known lesion or the presenting complaint. And the other type is screening mammogram, that is done on a well woman, asymptomatic patient. Now that is our concern today. So what is screening mammogram? That we know that is done on a normal woman. We have to invite them for a screening mammogram. What is our aim actually? If we are doing a screening mammogram, now as Dr. Padmaneswar mentioned, whatever screen, we have to detect some lesion early. So that's good. We are going to detect a lesion at a very early stage. We may detect a precancerous lesion, or we may detect if it's a cancer in non-invasive stage, and if it's an invasive cancer, we have to detect it at early age. So if we can do this, good. That is our target or the goal. And if you are planning a screening program, you should have some basic idea about these things also. What is the bilateral incidence? We get a synchronous. That's if you diagnose cancer in bilateral breast at the same time, or at least within 3 months of primary diagnosis. That is 1 to 2%. So you can't forget about the other breast. And the metachronous, that is diagnosis beyond after 3 months, still bilateral, it occurs in 5 to 6%. Why is this important? That is, mortality rate goes about, it is about 4 times higher in bilateral cancer if diagnosed within 5 years. So you have to remember this. So there are several advantages. If you are doing a proper screening program, if you detect a pre-malignant lesion, you can do a follow-up, or if you are willing, you can treat. Then if it's an invasive cancer, you have to detect early. If you detect early, of course, there are several gains. You can escape by mastectomy. You can avoid mastectomy, and by doing breast conservation surgery, you can avoid axillary clearance, which gives a lot of morbidity to our housewives, and you may even avoid chemotherapy. So it's a big advantage. If you detect an early cancer, you can avoid all these things and good morbidity. And if somebody is planning a screening program, you must have basic idea about how this breast presents. You have fatty breast and at the end very dense breast. About 10% have very fatty breast. We like this type of breast very much because it's very easy to diagnose lesions in this type of fatty breast. And about 40% have scattered density. Another 40% heterogeneous breast density, and the 10% very dense breast, where diagnosis is very difficult. And if you are going to do a screening program or a surveillance program, you should have pre-planned modules. We can just advertise a screening program and ask the people to come. So you should have preliminary modules. We have to define the population category. Whether we are going to do mass scale, island-wide or district-wide program. Then whether there's a special target group or some workers or officers or teachers. Then most important group is high-risk group, whether we are going to define limiting to the high-risk group or whether it's a random check. And we have to define the age group. It is 40 to 69. There are different age groups actually recommended by American College of Surgeons, American College of Radiologists and cancer societies. And they said there are different advantages of doing screening programs in different age groups. Say in 40 to 69, if you start early 40s, they say life years gained is more. Likewise, and 50 to 69, there's a peak incidence. That is the age group which we get peak incidence of cancer. So there are several advantages and also disadvantages. And we have to define the interval. Whether you are going to do annual mammogram, no point of just doing one mammogram in the screening program. You have to follow it up. So there's annual mammogram, biennial, that means 2 yearly. Now recently in UK they have recommended to start annual mammograms at 40 years to go until 55 and then to turn into biennial. Actually, in my personal experience, I worked in 9-10 years in cancer hospital and after that in private sector. I think this has to be decided individually, in my opinion, depending on their breast density, family history, and depending on the lesion we encounter, type of lesion. If it's purely fatty breast, we are sure no family history, no risk, completely normal, no point of asking this lady to come every year for a mammogram. So we can get away sometimes with ultrasound, but ultrasound is not the primary mode of screening, it's obvious mammogram, but we gain a lot on ultrasound scanning. I think Dr. Inzani Singh will take you in the discussion how much we gain on ultrasound scan added to the mammogram as an adjunct to mammogram. So we have to consider all those things and decide on the interval and the other setup. So anyway, a good screening program, we have to define the target group, then decide the interval, decide the starting age, and in my opinion, if we can at least cover this important high risk group, I think we have achieved a lot. That's the most important group at least. You know what high risk group is, I don't know time to go into those things. And then define the area, then we have to invite. These are normal people at our home. So how to do this? It's very complex. You can easily speak about screening program, but so how to invite? I mean, some countries they have women's registry on their age groups. I don't think, to my knowledge, we have a women's registry, and we don't have their contact addresses after 40 years. We have to catch these people after 40 years. Then I suggest, then we'll have to define some network for invitations. I think we can start from grassroots level. If you don't have a proper registry, we can collect data from Grava Sevaka division, then get the help from primary health care workers like midwives, well-women clinic, MOH clinic and so on. I think there are people who are extensively on these tasks than me to decide on those things. But still, I think we have to expect poor compliance in our society. Remember, about 80% things are rural population in our country. So it's always bound with poor education status, poor socio-economic background. And the other thing is, I have personal experience on this stigma. When a person has cancer, sometimes they are not exposed to it to their even immediate relations. They don't like to tell the neighbors. In fact, I started a very limited screening program for high-risk group when I was in cancer hospital. I pasted a colored coupon, I distributed a colored coupon to be pasted onto these cancer patients' records and told them to send their immediate relations over 40 years, their sisters and daughters. They send their daughters or mother, but they very rarely they send their sisters. Because I think the problem is, one problem is stigma, and another problem is they are not bothered. And how to increase this compliance? I think awareness program should go in parallel. And we should have a very strong task force to decide these modules and further planning. We can get Cancer Control Unit, Health Ministry, College of Radiologists, Association of General Practitioners, MOH clinics and other primary health care workers, all that. Not only that, what about the technical now? This, once you do a screening program, you have to diagnose. Our target is to diagnose early, not just diagnosis. Our purpose is to diagnose early disease. If it's a late stage, of course, surgeon can diagnose, GP can diagnose, they can feel the lump, send for biopsy, diagnose, or that. But even that case, remember, once you diagnose, we still need radiologists to assess the multifocal lesions and the other breast. You have to make sure before surgery that the other breast is negative. That's also, and remember bilateral incidence, you have to remember that. So what technical things we need, if you are doing a proper screening program, we need mobile machines. And conventional mobile machines, I never recommend this conventional type, it's now obsolete. Because we can't detect early lesion with conventional mammogram. True, we did that for years, but to go in par with other country statistics, we have to diagnose it early with a proper machine, digital. Then it's very expensive, about 40 million, 50 million, the digital machine itself. And to be mobile, we need a lower coach bus, 24-hour servicing generator. So it's added cost. And how many? So many other practical problems. Then, if you are using static machines, they may be located in hospitals, they may be in cancer centers, and can our radiologist or other staff accommodate? You have to think about all these things. And the workload. And remember the staff, with regard to staff, we need female radiographers. not male radiographers. We have to appoint female radiographers and the radiologist. And this slide I put now in customs. We have all these. Remember now, more modern security checks, screening devices, including sniffing dogs, but still drugs get escaped. See that they doing at the corner. So likewise, now once we do a costly screening program with huge investment, manpower, equipment, all efforts and time, increased workload, that and this, we can't afford to miss a lesion. And then comes the radiologist role. It's very important and immense. We have done all that screening. Now when we got a PET scan to cancer hospital, cancer patients thought that their cancers are cured. It's something like that, just to diagnose. So this is very important immense, and experience and skill matters a lot. Especially in mass reporting, lesions may get easily overlooked because it's a large number of. Now, when I was trained, my postgraduate training in UK, I worked with actually this director of London Breast Screening Program in 1995, Dr. Heather Bilavali. They do mass reporting rollers. They roll this thing and about hundreds are reported. It's very easily you can miss a early lesion. Early lesion. That's our purpose is to detect the early lesion. But here, mass reporting lesions are very subtle. Majority are normal. So we are seeing. Your must get used to this type of things. Otherwise, we tend to miss. And remember, we don't have best subspecialty yet in Sri Lanka. We are all general radiologists. Most of us are general radiologists. And if you are doing a vast island-wide program, it's so many practical problems. And we should have, I think, the radiological eye to detect these early lesions. And of course, then we need proper equipment. And this is how mass reporting is being done. Actually, if you can read the sentence, this Professor Susan Devali, Professor of Human Health, King's College. It's now being overrated, it means. And this is how a lesion is being used. This is still a digital mammogram, very subtle change, hardly anything even I can see here. But when it comes to tomosynthesis, we have detected a very typical BIRAD5 very advanced cancer. So no point of missing these things. This looks normal. On mass scale reporting, very easily one can miss this advanced cancer. And we can have double reading, it will increase by, if you put two radiologists to read the mammogram, sensitivity goes up and false positive rate comes down. That's again a challenge. This is again a subtle lesion, very easily we can miss. And ultrasound also very subtle, and MRI shows an advanced lesion. So if you detect a suspicious lesion, yes, refer to proper channel, things will be okay. Then comes the indeterminate lesion and earlier pre-malignant lesion. Earlier pre-malignant lesion can be indolent for life, as Dr. Padmanabhan mentioned. So if you don't diagnose, patient might live the whole lifespan. But once we diagnose, the question comes. And sometimes they are very subtle. The follow-up is very important. Patient is anxious throughout. How frequent you have to get down, it's a real practical problem. And with this intermediate opacity, but still we can't afford to leave any doubt. So additional mammogram images, other imaging like ultrasound, MRI, follow-up studies, you can't forget this patient. And then whether you have to decide whether it's good or bad, then might end up with a biopsy, and it should be false alarm and false positive ultimately. And as already mentioned, we can't forget about the anxiety and the stress until proved as negative. It's very significant, I think. We are creating anxiety and stress among our normal women. And good proper screening system with unaccepted guidelines, with diagnostic computers, with proper channel of reference to be commended and good. Then we have to think whether are we in the position to carry out it. And on radiologist perspective, at the end, diagnostic capability, efficiency and reliability should be made optimum in order to get the maximum benefit of screening. And overdiagnosis is disadvantageous and going to be too much medicine, as you mentioned. And misdiagnosis is again hazardous. And my suggestion at the end, try to have super centers, at least 1 or 2 per district with all facilities. Strengthen awareness programs via preventive care network and enhance clinical based examinations at various clinics. And what about self-based examination? That's a very important aspect. Our women are not used to this yet. Convince the value and should be made more familiar to our women and enhance the benefit of primary health care workers. If you have time, just see that highlighted things. And the initial, this proponent, Dr. Mike, now is against the screening. And it has become now more political fashion than a scientific fashion these days. So as you said, if you go to internet, you can twist either way you want, the advantage or the disadvantage. And so the statistics. Actually, this is a cinema. You have to decide. There's good, bad, or there's any ugly side of it. Thank you.
Thank you, Dr. Kanta and Samarikrama, for the presentation on mammography. Dr. Neomali Amarasen is the next speaker, and she will speak on overdiagnosis CT coronary angiography and overtreatment with stents. Dr. Neomali Amarasen, as you know, is in cardiology at Sri Jadavpura General Hospital.
Thank you. Sorry. I'd like to thank Dr. Kumar Mendis for having invited me to talk on this particular topic. It wasn't an easy one really, because I realized having it undertaken it, that there's very little data. Anyway, I'll do my best. Now the first part of it, which is the main part, is really on overdiagnosis with CT coronary angiography. The other one actually follows, because once you've made the diagnosis, you've got to do something and then you can stunt it. So this is a CT scanner, and this is the kind of pretty picture you get when you go and do a CT coronary angiogram. It's actually much nicer than my conventional coronary angiograms which we interventional cardiologists do, because we just inject a dye and you get this black and white CD, while here you get all these nice pictures. And it's become very popular, and the other problem is that just about anybody can request it, because this is available in the private sector and it is just done. But one should know some little thing about CT angiography, because actually CT is an important investigation, because it's used to evaluate suspected aortic dissection and thoracic aneurysms. It's used for suspected pulmonary embolism. Also, when you are doing radiofrequency ablation for atrial fibrillation, you look at your pulmonary veins that way. Then, of course, the coronary arteries. Also, it's used in the assessment of complex congenital heart disease, including anomalies of the coronary circulation, great vessels, chambers, and valves. Then, if you are going for, particularly if you are going for redo coronary artery bypass surgery, it is very useful in noting where the internal mammaries and various other arteries are. And evaluating the coronary artery bypass grafts also is quite important. But unfortunately, most people are really not aware of most of these users of this CT angiography. People do know about the CT pulmonary angiogram, but everybody is now totally focused on CT coronary angiograms, to the extent that most lay people also just want it done. It's actually a good tool, because it's a primary clinical application of cardiac CT is the performance of a non-invasive coronary CT angiogram among patients with symptoms suggestive of myocardial ischemia. Now that is the key word. The overall accuracy of a 64-slice CT angiogram is a sensitivity of 87 to 99% and a specificity of 93 to 96%. It is the coronary CT angiography for evaluating coronary artery disease is most useful in low to intermediate risk patients with angina or anginal equivalent. The negative predictive value of coronary CT angiography is uniformly high in studies, approaching 93 to 100%. In other words, coronary CT angiography is an excellent modality for ruling out coronary artery disease. So if any of you all want to know whether you are okay, just go and do a CT coronary angiogram. Once the rule is negative, you can be happy. But the real clinical applications of coronary CT is in the emergency department, where you can get a very typical heart patient where the other features like ECGs and all that are not supportive. And detection of a non-calcified plaque, evaluation after coronary artery bypass surgery, and imaging of coronary stents. Now, what I want to just discuss is a typical patient we get who, the bulk of the patients I believe who undergo CT coronary angiography in the private sector are like Mr. DS I'm talking about. He's 58 years, no symptoms, regularly exercises, no diabetes or hypertension, but his father died of an MI at 60 years. His cholesterol is about 255, triglycerides 104, good HDL 68, LDL 166. But because of this one risk factor and the family history, he was prescribed rosuvastatin 10 milligrams. And because he was so anxious, he was advised to undergo a CT coronary angiogram. Now the result was a moderate plaque in the proximal LAD. So immediately his rosuvastatin dose was increased to 40 milligrams and he was to diet more and exercise further. And his physician was very pleased at this result because he said it's a near serious coronary disease that required medical management. Now, are you surprised by this particular result? You shouldn't be, because we start developing our plaque from the time we are about 1 year old. And by the age of 50, most people would have plaque visible to a CT scan. Also, arteries narrowed by plaque are not necessarily a threat. So why should you do a CT coronary angiogram? I've just mentioned a few for and against criteria. For is to reduce the need for conventional angiograms, this invasive one. Actually, there is a certain group. I'm referring to some of these rather obese ladies who are finding it very difficult to go on a treadmill, who have typical chest pain. And actually, you don't really like to do an angiogram either, because even an angiogram on such people can be quite dicey because of the obesity. Now if you do this and you get a negative result, since the negative predictivity is pretty good, I would say that is a good indication. Also, conventional angiograms carry their own risks because it's an invasive procedure. Cost is an interesting thing because if you take the developed countries, actually a conventional angiogram is much more expensive than a CT coronary angiogram. Not in Sri Lanka though. If you take the most popular CT machine in one of the private hospitals, which is a 640 slice CT, it costs 40,000 rupees to do it as an outpatient. While a conventional coronary angiogram in that same private hospital, done as an inpatient, is 43,000. So it's completely different. So you have to think a little bit about that as well. Then patients come into the emergency department with chest pain but no clear evidence of heart attack. This is a reasonable investigation. Then the fourth one is the one which I think a lot of people are talking about. That is, supposing you see a patient who is asymptomatic, good effort tolerance, and he has got a critical block in his left main coronary artery or proximal LAD, both of which, if he blocks it off, he can just drop dead. Now that is what people keep talking about. Look, we found this. If it wasn't for the CT coronary angiogram, this man would have died. But this is like in a million cases, you get about a few. But to just get that particular patient, you have to then screen quite a lot of people. Then reassurance, as Professor Padmanabhan talked about, I mean, just to reassure you that you are okay. You see, that's also one of the reasons. You can also rule out coronary artery disease with high negative predictive values. Now, what's against is that there is no data that the CTCA prevents heart attacks in asymptomatic individuals. Additional lifetime risk of cancer is between 1 in 200 and 1 in 5,000. Everyone is forgetting about the radiation. If you look at the amount of radiation which a conventional coronary angiogram, it comes to 200 that milligrams. And we actually checked up with this same hospital and found out that it's 500 for a CTCA. So 2.5 times the radiation of a conventional coronary angiogram for a CTCA. And if a plaque needs stenting and you find this blockage in the CTCA, you have to do the conventional angiogram anyway. Now this, I'd like to talk a little bit about the radiation because nobody seems to be talking about it when it comes to CTCAs. And it actually shows that now here I'm talking about 16 slice and a 64 slice, and you can see that the 16 slice it's something like 8 point something, and 64 slice is 11 point odd, it's something like 15. The faster it is, the more the radiation is. So when I don't know what the 640 slice CT is compared to this. This is also an interesting slide because if you look at it, these are the radiation doses and cancer risks reported from various CT studies. And the first two are the CT coronary angiograms, the others are head CT, chest CT, pediatric abdomen, whole body CT, and so on. And you can see that actually these have got the highest amount of radiation. And just take a look at the male and female. The females are very much more at risk, and particularly if they're young females. So bear that in mind as well, because this is again something where actually there is the estimated lifetime attributable risks of cancer incidence associated with radiation dose from a single ECG-gated CT angiogram. And this is at different ages. So you can see that these are English males and females, USA males and females, and Hong Kong males and females, all of which are very similar. But you can see a 20-year-old female, whatever their nationality is at much higher risk of a cancer compared to its equivalent male counterpart. So bear in mind that when these young people come very excited about their chest pains, that you are really subjecting them to a cancer risk. I'm not even talking about the contrast because that is another aspect, because again we use more contrast for the CT coronary angiogram than for a conventional coronary angiogram. And contrast can, as you know, give rise to contrast nephropathy. Now the only sort of clear details I managed to actually get was really from the United States because of their very good national health insurance program. You see, Medicare pays for all this, and Medicare will pay for your mammogram. But then there's a lot of, up to now, there's been a lot of evidence that mammograms have been helped. But Medicare had found that they were down hundreds of millions of dollars because of the large number of CT coronary angiograms being performed. So what they did was they started, thinking a bit about it, and they said that they wanted a large-scale study to be conducted because there was no evidence that the CT scans provided any measurable medical benefit. But that's where they ran up against a problem. There is now a society of cardiovascular CT doctors, and there was about 4,500 at this particular point, which was in 2008. And they immediately lobbied the Congress as well as the Senate, and more than a dozen senators and 79 Congress representatives supported the society and urged Medicare to reconsider its plan. And there was so much of lobbying that Medicare gave way. So they're still paying for the CTCAs. In fact, these things are important, you see, because these are financial incentives. That this was in 2008, an investment per CT scanner was approximately $1 million. And in US, you get these groups, these practice groups. So what they do is they invest in a CT scanner. Now they've got to now having invested in it, you have to pay for it. So the thing is, the number of private cardiology practices owning CT scanners at that point was more than 1,000. And each private facility that owns a scanner needs to conduct about 3,000 tests to pay off a scanner. But what do you do when a patient really comes with a chest pain? Now, this was a nice little study which was to decide, do you do a coronary angiogram immediately or do you do some screening beforehand? So what they had was, they had a target population, patients with chest pain no history of MI, but able to perform an exercise test. Now, some of them were straight away sent for a coronary angiogram. Others, it was exercise ECG, stress echo, stress SPECT, and then the coronary angiogram. And the conclusions were that an exercise ECG, or preferably a stress echo, which is a lot more, has the sensitivity and specificity more, was quite adequate to diagnose mild to moderate coronary artery disease. If the patient is high risk, and now you have enough and more risk, the ways of assessing a risk of a patient. If a patient is high risk, you don't have to do any of these things. Go straight away for a conventional coronary angiogram. If you have somebody who says that when he walks 5 yards, he gets a chest discomfort going up his throat to his jaw, you do not have to do anything else. You go for the conventional coronary angiogram. There's no point in going and doing a CT coronary angiogram, seeing some plaques there, and then doing the coronary angiogram itself. So there is this promise, which was the prospective multicenter imaging study for evaluation of chest pain. You see, there is one other thing you can get out of the CT which is quite useful, and that is the calcium score. And here what they did was they randomized one group to anatomical testing strategy, that's with the CT, and the functional testing strategy, that's with the exercise tests and so on. And they followed up. This was a very big study because there were more than 8,000 patients in that. And what they really showed was when the calcium score was either very severe or moderate, it correlated with the patient events. You can see on the y-axis. And it was the same with the functional ones, where the functional, suppose you got a strongly positive stress test, which was functional severe, or again a positive stress test saying the second stage or so, those also correlated with the event percentage. So, and so ultimately what happened was moderate to severe abnormalities in both arms robustly predicted the events, and any abnormality on functional testing was significantly more specific for predicting events. Overall discriminatory ability for predicting primary endpoint was similar and fair for both the calcium score as well as functional testing. So this was, as I said, the largest comparison of prognostic value for both calcium score and functional testing. It demonstrated that chest pain populations referred for testing have a low event rate and both tests have significant strengths. The coronary calcium score for future cardiovascular events and functional testing for high specificity of cardiac events. Certainly, a CT coronary angiogram provides better prognostic and discriminatory power than either of them, but the question is, do you really have to use it for screening? So, now having talked about the CT coronary angiogram, just a few words about overtreatment with stents. In 2018, over 1.8 million stents were implanted in the United States. Of course, 1 million for the coronary arteries, the remainder for the peripheral vessels and various other parts of the body. But that's a lot. Now, this is how the plaque forms. I don't want to spend too much on that. But as you can see, you can have quite a good lumen, but with a thin fibrous cap, which makes it a vulnerable plaque. On the other hand, you can have a critical block with a thick fibrous cap, which is unlikely to rupture. So it is really not the percentage plaque which matters. It is the vulnerability of the plaque, and we still haven't got a very sort of a marketable product to go and tell us exactly how vulnerable the plaque is. Also, stenting is not without its own complications. You get stent thrombosis, either acute, subacute, or late. Myocardial infarctions, your wire or balloon can cause plaque shift. Coronary perforations, again with your wire and balloon. You can induce arrhythmias. You can get contrast nephropathy, and you can get a stroke. Now, these are just touching the tip of the iceberg. These are increasingly relevant as the benefits of the procedure become less clear. And this is what's interesting. This is just some data from the United States, where it really showed that, because you see, US is one place where, because of the amount of litigation and so on, a lot of people who have been doing unethical practices have actually had themselves been disbarred from practice. So if you look at the trends are that actually it's coming down. Now, this is just 2010 and 2013. You can see that there is a 7.2% drop in the total PCIs. And if you look at PCIs per 10,000, again, there is a drop. But if you look at patients with cardiogenic shock or left ventricular failure, there is an increase, because those are the people who need the stents. you see, the thing is, unfortunately, stents have been given a bad name because people are putting stents into 30% patients, asymptomatic patients, and so on. But stents are necessary. You need to put a stent when a patient comes with this kind of situation. So here you can see that from 19,000 has become 22,000, and that's with an increase in population, and 40,000 has become 59,000 in patients with left ventricular failure. So actually, the number should go up with the high-risk people, and it should come down with the others. This is again the Medicare beneficiaries, and here again you can see that actually if you just take the diagnostic catheterization, which is the upper line, again it peaked and then it's come down and it's plateaued. It's the same with the one with the diamonds, that's the PCIs using stents, and CABGs, as you can see, is on a downward trend anyway. I mean, there are many reasons for this. One thing is better medical management, good risk factor control, and so on. In fact, that is what we should concentrate on. And my final slide is, this is really from Israel. And this is quite nice because it shows the trends from 2002 to 2014. And you can see that in 2002, if you look at the red line, which is the PCI, there were 387 per 100,000. It rose to right up to in 2008, which was the stent mania era, where it went up to 423. And then it has now come down in 2014 to 378, which is even less than the 2002 one. And 2002, mind you, the drug-coated stents were not there. The stent mania came after the drug-coated stents came in. So it has actually dropped. CABG, as you can see, has been gradually dropping, and from 109 it has dropped to 46. But what's important is the way how this has leveled off. Unfortunately, we don't have good registries in this country, and I just couldn't trace anything from India because I don't think you'd get the same figures there. So that is what I really wanted to say, that the two are really related. Both you diagnose, you overdiagnose, and you overtreat. Because you can see something which is 80%, even though it's a perfectly stable plaque, you go and stent it. So the two, you might say, go together. But it is important to know that there's a lot more in this than that. And you have to really select your patients, both for investigation as well as treatment. Thank you.
Thank you, Emily. I'm sure we'll have an interesting discussion at the end. Now, next we'll have Dr. Dulani Kottachi, the consultant endocrinologist, to talk to us on diabetes and hypertension diagnosis. Should we lower the cutoff?
Very good afternoon to all of you, and I must thank Professor Kumar Mendis for the invitation. So let's talk about diabetes and hypertension, hot topics in non-communicable disease as well as same as ischemic heart disease. So to begin with, I'll be talking first on diabetes and then on hypertension. So let's start with diabetes. Okay, so as you all know, diabetes is it's an epidemic and it's growing day by day. We see more young patients coming to us with diabetes, and all has gone into now focusing on prevention. Can we prevent our generations, younger generations, from getting into diabetes? So prevention is important because they have found that lifestyle interventions, giving metformin combination, that can delay or even prevent the risk of having diabetes. So the focus is on prevention. I think never there have been a doubt about diagnosis of diabetes. As for the last almost 10-15 years, we have used the same criteria of fasting more than 126, a random blood sugar of 200 with symptoms. If you do an OGTT, the 2-hour value of more than 200, we've taken that with an HbA1c of more than 6.5 within the last 5 years. So that diagnosis has not been challenged at any point because that has proven that having these cutoff values will prevent them from, especially the microvascular complications in the next 10 years. So the problem to our region first can we use the same cutoff values of HbA1c 6.5, which was mainly designed for the Western world and had many studies on it? I'll just highlight one of it that's done using Indians, Malaysians, and Chinese people, and they have found yes, we can use it. So there's no argument about using HbA1c value of more than 6.5 in diagnosing diabetes in Asians as well. So both the Western and us Asians will have the same. So this is abstract saying we can use the same cutoffs. They looked at retinopathy and they have said yes, 6.5 is a good cutoff value to say can predict retinopathy in these all three people. So the problem is in pre-diabetes. So there's no question about diabetes. We know it. We know the diagnosis. But always there's a question about pre-diabetes. So when I see a patient, a young patient, coming to us with a fasting blood sugar of 102, 103, marginally elevated, they ask the question, can I get diabetes, doctor? So it's all individualized because we have to assess the risk of a patient. Just seeing one report of 103, just seeing one report of 110, that does not mean that the person is having pre-diabetes. So that always needs to be reviewed, and now it's not specified. It is not a clinical entity. So we can't label a person as having pre-diabetes. It is not a clinical entity, but a risk for diabetes. It's not a clinical entity. So that will increase the risk of diabetes, cardiovascular disease, and we use this term for people who does not match up to diabetes, but it's still high to become normal as well. So it's associated with obesity, dyslipidemia, hypertension. It's been proven, the association with pre-diabetes, these non-communicable diseases. So diagnosis for the last 10 years, even the 2008 ADA guidelines would give the same cutoff values of a fasting blood sugar more than 100, from 100 to 125, to a value after OGTT between 140 to 199. But most recently, they have added the HbA1c value of 5.7 to 6.4. So the last 10 years, we had the two cutoff values. So it has not changed over the last 10 years, the diagnosis of pre-diabetes. The WHO still uses the cutoff of 110 to diagnose the impaired fasting glucose. So why should we diagnose pre-diabetes? And is the cutoff too low? That's the question in this forum. To answer that, we need to find some negatives. So there are some prospective studies which have demonstrated, especially systemic reviews of 44,000 patients from 16 cohort studies. They have followed up these patients for 5 years, and they have said HbA1c level of 5.5 to 6, they have a 5-year risk of developing diabetes around 9 to 25%. So a person with an HbA1c level more than 6, up to 6.5, the risk of developing diabetes within the next 5 years is 25 to 50%. So that is where the problem comes in. So these people are vulnerable to have diabetes, and when we get a patient, we should explain to them, not that they're just going to immediately have diabetes, but you have a 5-year risk of developing diabetes. If you have an HbA1c of 6, you've got a 50% chance of developing diabetes within the next 5 years. So this is all about prevention of getting into diabetes. So Diabetes Care have published this article regarding the systemic review. And they have shown clearly, you can see the association between the annual incidence of diabetes and the HbA1c level. So it increases with the HbA1c level. It's been statistically proven as well. So we had a study done in 2012, the BPPP study, where we have showed that HbA1c is a predictor for us to say whether a person can go into diabetes or not. So it's a very good predictor to say that. So in all this, they have said HbA1c level of 5.5 to 6.5, although we use 5.7 as a cutoff, this 1% will capture a large proportion of people at high risk of developing diabetes. So if you do some interventions like lifestyle interventions, if you give them metformin in indicated patients or combine in especially obese people, we can significantly reduce the risk of diabetes. So I think there's no question about the cutoff values at this point regarding the pre-diabetes or the diabetes. The problem comes also with the screening. So the Western world have criteria. They say, okay, if you are Asian, you have to get yourself tested for diabetes. If you have a polycystic patient, yes. If you've had a large baby, yes, you screen for diabetes. But us, being Asians itself, we are at risk of developing diabetes. So I don't think we should have these criteria for us to say whether we should get ourselves screened. No, because being Asian itself, like in GDM, we have put ourselves at risk. So that we need to screen ourselves for diabetes. So cutoff for pre-diabetes, in my opinion, is not too low. It hasn't been changed for the last 10 years. But patients need to be educated regarding the risk of development of diabetes. So shall we move on to hypertension? As Professor Kumar Mendy said, the big ha-hoo about the change of guidelines was in 2017, when HA decided with the American Cardiology Association that, okay, we are going to change especially the naming or diagnosis of hypertension. And so I have a word about the JNC8, Joint National Committee Guidelines, which we have used from 2013, the differences and why this difference came up. So what's the change? So you can see clearly the systolic blood pressure of less than 120/80 is absolutely normal. So in JNC7 they said it, and 2017 the AHA said it. So what's the difference? The labeling of the hypertension. So JNC7 said it's pre-hypertension when you have a systolic blood pressure of 120 to 129. And the AHA said it's elevated blood pressure. So nomenclature got different here. And they defined, JNC defined pre-hypertension still when the blood pressure is 130 over 139. So you can see from 120 to 139, big range, they are pre-hypertension. But in AHA, it's now coming to stage 1 hypertension. So more than 130 of systolic blood pressure. And if you have a diastolic blood pressure over 90, you have stage 1 hypertension. So stage 1 hypertension in JNC was when the blood pressure was 140. And the AHA is only stage 2. So above stage 2 in AHA guidelines, 140 above 90, you are diagnosed with stage 2 hypertension. So this is the difference between these two guidelines, and the reason for the change of nomenclature from pre-hypertension to elevated blood pressure. So what they thought, if I say to a patient, you are pre-hypertensive, they might not take it seriously. So that's the reason they wanted to change nomenclature, but that caused big chaos in the world of people who manage hypertension. And so this is the guideline where they have published in 2017 under high criticism for the cutoffs. So the problem is regarding the targets of treatment. Okay, you can define hypertension, but then we have decided which stage we are going to treat this patient. So from the AHA guideline, they have said elevated blood pressure above 120 to 130, don't treat, you do the lifestyle modification. You let the patient lose weight, do the diet, reduce sodium, enhance the potassium intake, reduce alcohol and smoking. That's lifestyle. So stage 1 hypertension, you might give medications if you have a cardiovascular risk of more than 10%. So you have to calculate here. So all the patients above 130 will not be treated unless they have a cardiovascular risk of more than 10%. So this is secondary prevention for cardiovascular risk. So stage 2 hypertension above 140, yes, you start treatment if it is persistently elevated. So the diastolic pressure goes along with it. So the difference from the JNC8, which is the latest from 2013, is we treat anyone above 60 years if you have a systolic blood pressure above 150 over 90. If your age is less than 60, you have a blood pressure of 140 over 90 is the cutoff you treat. So you can see clearly the difference of target of treatment. That is where the problem came in. People thought you are treating blood pressure at a very young, very low stage where it's not necessary to treat. But I think HA is very tool is not necessary to treat, but you have to calculate the cardiovascular risk and then decide whether you want to treat. And the reason why they got these results was the other thing. How did they come up with this 120, 130 suddenly? It's to do with the sprint trial they had very like closer together before they made this AHA guideline. And it's heavily criticized because the AHA guideline was made by the same person who was involved in the sprint trial. So it's intellectually there was conflicts, intellectual conflict of interest. So what they say is the sprint trial head was the chairman of this AHA guideline committee as well. So the GP Association in US, the Family General Physicians Association, they refused ultimately saying we're not going to follow this AHA guideline. We're going back to what it was in 2015 and we follow that because of this intellectual problem of the interest. So they have said increase the hazard ratios for cardiovascular disease and stroke have increased to 1.1 to 1.5 when we increase your systolic blood pressure to 120 to 129. So it's 1.5 to 2, the hazard ratio. It's 2 times the risk of having a stroke or a cardiovascular disease if you have a blood pressure above 130. This is from the sprint trial itself. So this is where the problem came in, and what they have found is the risk gradient was consistent across all the subgroups in their study, and there's no difference with the sex or the race or the ethnicity. So this is what they really found. And there is a meta-analysis also as well. With 1 million adults, they have said, okay, if you reduce the blood pressure, mean blood pressure by 2 millimeters, there's 7% reduction in risk of ischemic heart disease or mortality. Okay, we agree 10% reduction in risk of stroke and mortality. So there's no argument about it. If you reduce the blood pressure, your risk of cardiovascular disease and stroke will reduce. And same if you the risk of mortality will double if you increase your systolic or diastolic blood pressure by respectively by 20 and 30. So you can see with the increase in blood pressure, your cardiovascular mortality will go up. So there's no question about it. But the problem was with the lowering of the cutoff for diagnosis and treatment. You can see saying here, relative risk of cardiovascular disease go up when you have a higher blood pressure. So you can see the start of this gradient, the graph I've shown you, starts from systolic blood pressure of 115 over 75 and gradually it increases, but not linearly. So evidence suggests that blood pressure diagnosis cutoffs should be low, that's with evidence, but in real life, as I said, we have increased the number of people who are diagnosed with hypertension from 32% in US to 46%. That's a huge percentage. And undue stress to the individual and the burden of healthcare cost. So it is really for us, the local guidelines, to say whether we are going to adapt these newer guidelines or we are going to stick to the previous guidelines and watch and wait and see how things move on in the Western world as well before jumping and diagnosing people with high blood pressure. Because in the sprint trial, they have measured blood pressure when a person is seated after 5 minutes. When seated 5 minutes, they have taken the blood pressure. But you and I know in clinic setups, we can't make a patient sit for 5 minutes to do a blood pressure. The patient comes in, we measure the blood pressure. So actually whether we have done it in the ideal setup where we can't do it. So I think it's very difficult to correlate your clinical with the research aspect of the trial setup into normal clinical practice. So I think it is our judgment to decide on the cutoffs and treat accordingly to our patients, and at least have 2 readings of blood pressure when you start treatment, because just seeing one's reading of 145 over 90, don't jump into diagnosis of hypertension, and that person must have run from basalt to your practice, you never know. So be a bit liberal about diagnosis of hypertension. Okay, thank you.
Thank you, Dr. Nani Kottaki for the talk on diabetes and hypertension. Should we lower the cutoff? Thank you for the very comprehensive talk. We next have Dr. Ananda Vijayavikrama from the National Institute of Infectious Disease, and he will speak on has guidelines changed in the diagnosis and treatment of influenza.
Good afternoon, everybody. Thank you, Madam and Professor Kumar Mendis, for inviting me for this interesting and important symposium. I think nowadays we have started seeing influenza patients, so it has become current topic, which makes my talk probably a bit more appealing and easy also. First, I thought of giving a brief description of influenza, but I'm sure most of you know it, but to make it complete. Influenza is a respiratory illness of sudden onset caused by an influenza virus. It can be the symptom and the consequences can range from mild to severe. And it is a highly infectious disease, spread rapidly from person to person. And the important thing is some strains of the influenza virus cause more severe illness than others. And we get this every year, generally in outbreaks. It's an RNA virus. There are 3 virus types, influenza A, B, and C. And this is the influenza virus in the picture form. It is important to note that there are many antigens in the world. Especially important ones are hemoglobin and neuraminidase, which change from time to time and rapidly, and which has led to the nomenclature of this various type of influenza virus. These changes are called antigen drift and shift. The drift is a major change in the form of one of both two principal antigens, that is the H and N, and the antigen shift is also the changes, more radical change in those. Influenza A is one species of influenza virus. The natural host is a wild aquatic birds. Occasionally it can transmit to other species and can cause devastating outbreaks in domestic poultry and give rise to human influenza pandemic. Type A is the most virulent virus, and influenza type of the influenza type which causes severe disease. The influenza A can be subdivided into different serotypes based on antigenicity, based mainly on the H and N antigen. And as I said, some of these have caused severe or large outbreaks, out of which the H1N1, which caused the Spanish flu in 1918 and the swine flu in 2009. The 1918 one was a very significant outbreak. Then there was a H2N2 which caused Asian flu in 1957. H3N2 caused Hong Kong flu in 1968. And then there are the combination from time to time which has caused outbreaks. Out of these, influenza B is almost exclusively infects human and is less common than influenza B. It mutates at a much slower rate, so there are not much of genetic diversity. And reduced rate of antigenic change combined with its limited host range ensures that pandemic of influenza B does not occur. Influenza C virus infects human, dogs, and pigs, sometimes causing both severe illness and local epidemics. However, it's a less common type than other types of influenza. These are some of the pandemics causing large number of deaths, especially the Spanish flu, which was due to H1N1, which the estimate of deaths during that period is about 40 to 100 million. And this whole picture in that outbreak where patients are managed like this. And it is estimated that it may have killed as many people as bubonic plague or Black Death. The majority of deaths were from secondary infections such as bacterial pneumonia. It killed between 2 to 20% of those infected. It mostly killed young adults, with more than half of deaths in people between 20 to 40 years. And it is estimated it killed as many as 25 million in the first 25 weeks. So you can see there have been many outbreaks causing these deaths. The symptoms, as you know, it causes sudden onset of symptoms with fever and extreme coldness, with chills, rigors, and cough, nasal congestion, runny nose, sneezing, body aches. Those are common symptoms, with fatigue and headache. And then you get watery eyes, petechial rash in some people. The incubation period is about 1 to 4 days. And spread by breathing in droplets, which are produced when infected person talks, coughs, or sneezes, or by touching an infected person or surface contaminated with the virus, and then touching your own face or someone else's face. With the first patient we had in our ICU in 2006 years ago, I think. A pregnant lady transferred from Ratnapura. She was admitted there with cough and shortness of breath. She rapidly went into respiratory failure, intubated, ventilated, and it was positive for H1N1. Then she was transferred to us on 1st of December, where we were not ready to accept the patient to the ICU, but we had no option. She was on intermittent positive pressure ventilating, needing high concentration of oxygen and a high PEEP. She was started on seltamivir and post-spectrum antibiotics. She went into a spontaneous abortion, and so we had to take her to DMH for the dilatation and evacuation. And then she developed surgical emphysema, and this chest X-ray on day 4 of illness, and this chest X-ray on day 10 of illness. So she had the prolonged ICU stay. Somehow we were able to get out of the ventilator, and after more than a month of ICU stay, she went home. He's another 24-year-old boy admitted with cough and shortness of breath for 3 days duration, had high fever and loose motion. He has been a heavy smoker. He had rapid deterioration of symptoms, worsening shortness of breath, oxygen saturation went down. This is chest X-ray. You can see bilateral shadows, alveolar shadows. He was started on oxygen or seltamivir. As he was getting worse, we started him on antibiotics as well. Then the X-ray was getting worse, shadows were spreading, and he was started on CPAP, did the CT scan of chest showing again bilateral involvement of lungs. You can see how the X-ray got worse, and somehow he survived. So you can see this, we are facing with a condition which has led to millions of deaths, and some people have rapidly deteriorated and died. So we need to diagnose and treat these patients, isn't it? So the question is how to manage these patients. So it is important to understand when to test these patients. I have used the latest guidelines produced by the clinical practice guideline by the Infectious Disease Society of America, which was published in December 2018. So they have categorized this testing in different kind of patients. First, in outpatients, and during influenza activity, and also when there's low activity of influenza in the community. So what they recommend is now, and it is important to understand that these recommendations are not for America, not for us. But I thought of showing these recommendations because we don't have our recent, we haven't updated our recent recommendation. So it is important to see what they say, and then probably devise recommendations for us. In a season of influenza activity, what they recommend is to test for people with high-risk patients with acute respiratory symptoms and patients with acute onset respiratory symptoms and either exacerbation of chronic medical condition or known complications of influenza like pneumonia. And then also they say can consider influenza testing for patients not at high risk if the results might influence antiviral treatment decisions or reduce the use of unnecessary antibiotics, further diagnostic testing, etc. And then when it is not seasonal or have a low influenza activity, to test patients with acute onset of respiratory symptoms with or without fever, especially for immunocompromised and high-risk patients. Now, it is not essential to test all the patients in an outbreak, because when there is an outbreak, the clinical diagnosis has to be made, and the decision of treatment should be based on the clinical diagnosis as well as the patient's clinical condition. In hospitalized patients, this is the recommendation again. During influenza activity, patients requiring hospitalization with acute respiratory illness. That means they have significant symptoms which need them to be hospitalized. And patients with acute worsening of other cardiopulmonary, chronic cardiopulmonary diseases, patients, immunocompromised patients, patients who while hospitalized develop acute onset respiratory symptoms. They are hospitalized for other things, but then in the hospital they develop respiratory illness. And then during a period of low influenza activity, again patients requiring hospitalization with acute respiratory illness, and then in immunocompromised patients. So there are some restrictions on testing of these patients, and then based on those we have to decide whether to start these patients on treatment or not. The available treatment at present in Sri Lanka is the oseltamivir. Other treatment available in other countries is inhaled zanamivir and intravenous peramivir. The important thing here is the study. There have been many studies done on use of oseltamivir. The benefits shown are very small or very limited in otherwise healthy adults. There have been significant benefits in people who have other comorbidities like the immunocompromised patient due to various reasons. But in healthy adults, the advantages shown by studies are very limited. It is limited to improvement, say less than 1 day off work, or less than 1 day hospital stay. Those are the type of benefits shown by the studies. But then it is important to start treatment in high-risk categories. Now, the high-risk categories are the pregnant women, people above 65 years or older, then children younger than 2 years of age, and people with underlying health conditions like immunosuppression, asthma, diabetes, or heart disease. These categories, there is more benefit in starting treatment on these categories. So if a patient needs hospitalization due to acute respiratory illness, and if we suspect possible influenza, such patients need to be started on antivirals because they are ill. And then at outpatients of any age with severe progressive illness, regardless of the illness duration. If the patient is symptomatically getting worse, progressively worse, then outpatients who are at risk of complications from influenza due to their other comorbid factors, children younger than 2 years and adults older than 2 years, and pregnant women or within 2 weeks of postpartum. So this is the recommended group of treatment to start on antiviral drugs by the International Society of Infectious Diseases in the latest update of the guideline. Then there's a question whether these patients need steroids. The recommendation is that these patients should not be on steroids as adjunctive therapy for the treatment unless clinically indicated for other reasons. There are different reasons. Say if asthmatic get possible influenza, and if the asthma condition is getting worse, then such patient might need starting steroids, but not as treatment or adjunctive treatment for influenza because it has shown to prolong the period of virus in lungs. Then another important aspect is the starting of antibiotics. I don't know whether you noticed in one of the slides, the first slide, my first slides, I showed that the reason for many deaths of these patients was due to secondary bacterial pneumonia. And it is the problem in our situation also. And many of these patients have been started on antibiotics too early during the viral stage of the illness. And by the time they get secondary bacterial infections, they are resistant to many of the commonly used antibiotics. And they die of pneumonia or they get fungal pneumonia. Unfortunately, there is a practice among some people to use antibiotics as antipyretics. For every fever, antibiotics are being started. And unfortunately, surprisingly, the patients are told that they are having a viral infection and still they are given an antibiotic. So then when should we start antibiotics? In patients with suspected or diagnosed influenza patients. This is the recommended guideline. Investigate and empirically treat bacterial co-infections in patients who present initially with severe disease. If somebody comes with hypoxia with respiratory symptoms suggestive of influenza, then we need to put them on antivirus as well as antibiotics. Then investigate and empirically treat bacterial co-infection in patients who deteriorate after initial improvement, particularly in those treated with antibiotics. So they initially improve with antivirus, but then they get secondary bacterial infection, and such patients need investigation and treatment. And then we have to consider starting antibiotics those who fail to improve with antiviral therapy after 3 to 5 days of treatment. And another thing I wish to highlight is this guideline says to investigate and treat these patients. So these patients need sputum cultures, and then start, pending the results, you can start antibiotics if the criteria fits. Regarding prophylaxis in the guideline, there is no level A evidence in the guideline to show, the latest guideline to show the prophylaxis is effective. However, they have recommended with level B2 evidence to consider antiviral chemoprophylaxis for the duration of influenza season for adults and children aged more than 3 months who have the highest risk of influenza associated complications, such as recipient of hematopoietic stem cell transplant in the first 6 to 12 months post transplant and lung transplant recipients. So these are highly immunocompromised patients, and in such patients they recommend consideration of antiviral chemoprophylaxis. But the important thing is you have to give this prophylaxis until the season is over. So maybe several months, weeks or months. This is sort of putting a slide or two on vaccination. This is what is in the latest Cochrane review, which was published again in December last year. Healthy adults who receive the summary of findings, healthy adults who receive inactivated parenteral influenza vaccine rather than no vaccine probably experience less influenza from just over 2% to just under 1%. So that's the reduction or the effectiveness of the vaccine. So there is moderate certainty evidence for the use of vaccine. They also probably experience less ILI following vaccination, but the degree of benefit when expressed in absolute terms varied across different settings. Variation in protection against ILI may be due to part to inconsistent symptom classification.
Just 1 minute more, please.
Yeah. Then it goes on to say protection against influenza and ILI in mothers and newborns was smaller than the effects seen in other populations considered in this review. Vaccine increased the risk of number of adverse effects. That part is not very important, but the last sentence seems to be very important. 15 included trials, included RCTs, were industry funded. So there had been many industry funded trials on influenza vaccine, and you can see how they can influence, like the case shown by use of CT scans in America. Thank you.
Thank you. The last speaker for today is Dr. Udana Ratnapala, who doesn't have CKD.
Okay, thank you very much, sir. So I think we are coming to the last kind of lecture on this mind-blowing topic. Of course, thank you, Professor Kumar Mendis, for inviting me. And half of the house here are my teachers. So, let me try to ask the first question because of that. I would like to do a head count out of you all. What number would be labeled as CKD in this house? I'm sure it will be 50%. Okay. Yes, so I saw kind of a debate between clinicians and statisticians and community physicians. Clinicians seems to be happy with the definitions and they're happy to do whatever that is told by the guidelines, but I think community physicians are a bit different. They think there's a lot of overdiagnosis and overtreatment. I think I'm in the kind of receiving end of all this trouble being a renal physician. Let me prove it. So the first slide I am going to discuss would be the definition again, what is chronic kidney disease. So this definition was given in 2002, later on it was amended in 2013, right? And this was developed by Kidney Disease Improving Global Outcomes Group in collaboration with National Kidney Foundation in USA. After this definition, of course, most of the countries do adopt this definition and most of the nephrologists all around the world do use this definition. Now the broad definition would be CKD is defined as any abnormality in kidney structure or any abnormality in kidney function which lasts for more than 3 months with implications for health. If there is any problem in your kidney structure, if there is any problem in your kidney function lasts for more than 3 months, you have got CKD. Then there are two parts of the definition. If there are markers of kidney damage lasting for more than 3 months, we will be talking about these markers of kidney damage, or the glomerular filtration rate, which is the amount of blood filtered through the kidney over a 1 minute period per square area. If it is less than 60, once again, which is an arbitrary value, right? Where the 60 comes from, no one knows. But we will be what we called try to criticize this definition, and we'll try to explain the amount of trouble that a nephrologist is in because of this definition, right? So what are the evidence of kidney damage? So if you have albuminuria more than 30 milligram per gram, or just a simple protein leak for more than 3 months, you have got CKD. Now this could be transient due to orthostatic proteinuria, we call it. If there is chronic inflammation process, chronic infective process, if there is albuminuria, then you have got CKD. Then any urinary sediment abnormalities, for example, if you have microscopic hematuria, which could be due to renal calcular disease lasting for 3 months. If you have white cell cast, if you have red cell cast, or if you have oval fat bodies due to nephrotic syndrome, you have got CKD. Then any electrolyte abnormalities and tubular disorders, for example, renal tubular acidosis type 1, 2, 3, 4, or nephrogenic diabetes insipidus, or potassium or salt-based nephropathies lasting for more than 3 months, you have got CKD. I am sure many of you have one of these. Then histological changes, if you undergo biopsy, if there are glomerular changes like glomerulopathy, tubular changes like tubulopathy, or vascular changes, still you have got CKD, and this is more important. It's quite a practice for our radiologists to do a scan of the kidneys, and if there is Wozniak type 2 cyst, which lasts for 3 months, if there is a calculi causing obstruction and hydronephrosis for 3 months, if there is renal artery stenosis for 3 months, if there is dysplastic kidney, single functioning kidney, or if there is polycystic kidneys, or any cystic kidney for that matter, if it is there for 3 months, you have got CKD. So you can see the definition is so loose. If we adapt this definition, there will be loads of CKDs and we will be overwhelmed with birth. So they came with the second definition. So the second definition is reduced GFR of 60 mils per minute per standard square meter. Now whether the 60 is going to solve our problem is the question. Now this value was obviously obtained from a young adult's GFR, which is roughly 120 mils per minute. So they have roughly taken a value of 60 and told us this is the cutoff for CKD. Now to come up with the absolute GFR, you have to do what we call, you have to give a substance to the patient which is excreted by the kidney, then measure the concentration in the plasma, measure the concentration in the urine and the volume, and you have to calculate the absolute GFR by using inulin, chromium EDTA, technetium, so on and so forth, which is a cumbersome procedure, is an expensive procedure. So for clinical purposes, we can't use absolute GFR, as you all know. So what we are doing these days is there are formulas to calculate estimated GFR by using a molecule in the body such as creatinine or cystatin C. Now, do you think it's without any trouble? It gives rise to loads of trouble. Now, these are the three frequently used formulas in the country or in the world at the moment. So, for Croft-Gall, there is a creatinine at some point, and as the denominator, age. And also in MDRD calculation, then creatinine comes in and age comes as the denominator. And CKDAP, no difference, age comes as the denominator. So as you can see, if the age comes as the denominator, by increasing the age alone, what will happen to your GFR? It will drop, right? So I'm sure, I'm not going to tell my age, but if I compare with my teacher who has got same creatinine, she will have CKD, I will not have. Let me prove it. So this is the calculation I did, before going to the calculation, now this is the guideline by using the GFR. They have defined 5 categories, all of you know that, CKD stage 1 to 5, and by albuminuria, micro, macro, and more than that, so we call subnephrotic. So this is A1, A2 and A3. So this gives some idea about the prognosis of the patient. But even patient with normal GFR, patient will be in CKD stage 1 category. Okay. So now this is the effect on age on eGFR alone. You and me are, so for example, there are 3 people, all are males, 30 years, 60 years, 85 years. And the creatinine is 1.2, the upper limit of normal. All are muscular people, so they are not like me, right? Obviously not like you. And none seems to be muscular in this group. Anyways, so 1.2 is good for a muscular person, not for you all. But 1.2 in 30, 60 and 85 males, all are non-Baxo Asians. Now I am going to use the MDRD formula for CKD-AP formula, which can be downloaded from the Google App Store. And I have calculated, first for the 30-year-old gentleman, the eGFR comes to 71. For the 60-year-old patient, eGFR comes to 62. For the 85-year-old patient, eGFR comes to 58. For this 85-year-old gentleman, which doesn't have any evidence of CKD whatsoever, will be categorized as CKD stage 3A. Accepted? Not accepted. Okay, we'll see. Yeah, the next question we see. Now, this is only because of the report given by the private sector, government sector, or eGFR calculated by your formula. If you go with eGFR alone, you will be overdiagnosing CKD, right? Then you use the gender. Oh, it's tremendous. The gender difference between, give the effect of gender on creatinine. Once again, this gentleman, male, 30 years, creatinine is 1.2. Female, 30, creatinine is 1.2. Quite huge female, I would say. Yes, then we will calculate the eGFR using MDRD. Male, the same calculation, 71 mils per minute. Look at the female at 30 years of age, very young. eGFR comes to 53. The diagnosis, CKD stage 3A. So you refer to me. It's good for the private practice, but not good for the government practice. You see? So this is the problem in Sri Lanka. Sri Lanka is a country. I have got very limited experience when compared to my teachers, but we don't mind the increased number of patients in the country, but in the private practice especially. But these are problems, these are unnecessary referrals, right? Then what does this definition does? If you select CKDs depending on the definition alone or markers of kidney disease, it's like a fishing trawler which captures many more innocent subjects than it should. So the plan was to catch maybe tuna, but there are dolphins, there are spread, and all the problems are there in this CKD group. If you come to my clinic where I work at Mathura or in Badul, where they do screening programs, I will get all these referrals from presidential task force and all these screening programs. It's very sorry to say, but they are doing the correct thing of screening, but the screening has no purpose. So that's what has happened to CKD screening in the country. But they have kind of captured a lot of high serum creatinine, that's good, but there are loads of false referrals or unnecessary referrals due to the screening program as well. So let's look at the statistics from developed countries. This is from USA. Estimated prevalence of CKD from 2001 study based on age and gender adjusted creatinine was only 1.7%. So roughly 1 in 50 accepted as the CKD rate we would think that is there in USA. But estimated prevalence of new definition, the CKD from new definition, USA it has risen to 14% and Australia it has risen to 1 in 6. 16%. So by using this definition, if you refer patients depending on this definition alone, there will be loads of CKD. So benefits of overdiagnosis, of course there are benefits of getting this kind of a definition. We might be able to early detect and slow or stop or reverse progression towards end-stage renal failure. As you all know, end-stage renal failure is incredibly difficult to manage in any country in the world because of the costs involved. Now, hemodialysis, if you do in the private sector, one session is 10,000 rupees and 3 times a week, 30,000 rupees, and it will be 1,20,000 rupees per month, and it will be 14 lakhs per annum. So, I'm sure I can't afford it. I don't know how many in the audience can afford that kind of money for dialysis. And the transplant, live donor transplant, costs 18 lakhs to 31 lakhs in the private sector. You see, it's huge cost for end-stage renal failure. So if we detect these kind of people early, we might be able to slow down the progression. That's one theory. And end-stage renal failure reduces the lifespan significantly. You know, when we start a patient on dialysis at the age of 65 in the best of best centers, the lifespan is only 2.5 years, right? Even in developed countries. So if we can stop people going to end-stage renal failure, there will be a benefit. And reduced EGFR or albuminuria were consistently associated with higher cardiovascular mortality. So lower your EGFR or higher your albuminuria, the chance of developing a myocardial infarction or a stroke is high. Because of that, if we halt this EGFR at a higher level or albuminuria at a lower level, there may be benefit for the patient. So these are the rationale, and of course late referral for CKD. I'm sure the problems faced by the physicians in the past and nephrologists in the nowadays, there are a lot of crash landers, we call it. People come with creatinine of 500 from nowhere and they come uremic, you have to put a line gets infected, or patient can throw arrhythmia and patient can die on admission also, and the outcome is poor. So you can't plan any renal replacement therapy if the patients come late. And CKD is the most important risk factor for AKI. So if you know that this patient has got CKD, for example, with a patient of creatinine of 1.2, if patient is labeled as CKD, of course, when patient comes with the influenza A, of course, the clinicians will be more what we call cautious in giving the oseltamivir dose. You know, the dose is 75 mg BD. Now, it's a frequent AKI I see for patients with CKD stage 3 and below. You can't give oseltamivir 75 BD. You have to come down to 75 daily or sometimes 30 weekly in CKD stage 5 and so on and so forth. So this dose reduction is not happening in the normal day-to-day practice. So if the patient is labeled as CKD, people will take precautions. For example, cardiologists, pneumology, and all, if patient comes with myocardial infarction, they will be more cautious and might do a referral also for contrast prophylaxis, and they might not go and do a what we call contrast study on them straight away. So there is a benefit of labeling these patients as CKD, and of course increase public and professional awareness. I think it's more than, I think Sri Lanka is the country which has given most emphasis for CKD at the moment, starting from His Excellency himself. Just coming to the drawbacks, so cost implications of diagnosing, treating and follow-up. I think we have been discussing from the early afternoon that we have to treat thousands of patients to prevent one end-stage renal failure, peak end-stage renal failure, like those examples I discussed. And adverse effects of labeling healthy and asymptomatic people as having chronic kidney disease. Now, there is a huge problem of CKD patients being labeled as CKD. If you come to my clinic on a Wednesday, there will be at least 30 patients waiting in a queue to get my signature for benefits from social services department. But actually, most of them are what we call resolved AKL or nephrotics with normal creatinine who can go and do any work at their will. But most patients do play a sick role when you label them as CKD. They don't do any work, not even look after their grandchildren. So most of my patients are like DLW. They would wait at home, come and see me in the clinic and go back and do the DLW job at home. So that's why I don't like overdiagnosing patients. They don't go to work and that decreases their quality of life. Then thirdly, this is some area that I like to emphasize on: patients could be falsely identified as having CKD and receive unnecessary treatment and diagnostic interventions. I think this is a problem that we see as nephrologists. For example, as a junior nephrologist, I see this regime being practiced in the country. If a patient is diagnosed with CKD, may at the general practitioner or at the physician level or at the nephrology level itself, we might start this regime. So first is no proteins. No low protein diet. That's the first advice they get when they are diagnosed with any CKD stage. Then the next advice is kahapata elewal palthuru kanna baya, gaslavu, kehelgedi, watana wattatta, pavilion, pala, kira kanna baya. So you can't eat anything. Then the third thing is there is a thing called CKD regime. Most of the doctors do start this patient on calcium carbonate, 1-alpha, alpha calcidol, and iron folic acid vitamin B complex. Let me look this from a more analytical side effect. Now, low protein is not good for any grade of CKD. They need proteins because your muscle mass is due to proteins. You can't maintain a muscle mass. You develop proximal myopathy, and all your enzymes, cofactors need essential amino acids. So even the guidelines have recommended at least amount of. So this is the classical picture of a European patient who is being dialyzed, and this is the typical subcontinent patient. You can barely see any muscle here, and he is nicely, you can see the muscles, and he is well built because of very low protein diet prescribed by us. Now the recommendation is to give 0.8 grams per kilogram, the minimum. So even for a 50 kilogram patient, I don't see 50 kilograms here, all are 60 and above. No 50s nowadays. Anyways, so this is for a 50 kilo patient. You can give 2 servings, and that would be 2 30-gram pieces. So we can all size scale dekak mas malu kana bulan dawasata. So that's the amount we should give. The minimal amount we should give, and the maximum would be 4.5 pieces of fish meat. So I think it's a wrong advice, and this wrong advice given for a wrong diagnosis is going to create trouble, and it's going to result in proximal myopathy and no muscle power to withstand dialysis, to withstand transplant. So most of are like DLW because of this wrong advice. Second wrong advice: low potassium diet. Now, should we advise low potassium diet in all? That's again a mistake we do. Now, potassium is needed for polarization of cells, and for muscle function and for nervous function, you need potassium. So it is very clear that when the potassium goes above 5 milliequals, you should advise on start cutting down potassium. Until such time, you need to give a normal potassium diet. So giving this wrong advice for wrong diagnosis is detrimental, and it has happened over the years. Third, can you give calcium carbonate and 1-alpha? Now, this is a routine practice. People can disagree with me, but it's a routine practice to add these two, thinking that patient is vitamin D deficient, thinking that patient needs calcium due to hypothalcemia. But all of us know that there are 5 types of mineral bone disease due to CKD itself. So if it is a clear-cut CKD, this may be a clear-cut CKD, and still you can have 5 types of mineral bone disease. So if you put 1-alpha calciferol or vitamin D blindly, for example, in secondary hypoparathyroidism with high phosphate, what will happen? The action of vitamin D is to absorb more phosphate. So phosphate level will become more high, and phosphate is an independent risk factor for cardiovascular mortality. So there will be more work for the cardiologist. More MIs, more strokes. I think that's what we have been doing. Very good. But second example, if the patient is in adenoid bone disease, if you give too much vitamin D again, once again, the bone marrow will shut down, the bone growth will stop. So all in all, we should do a proper assessment of mineral bone disease. So to diagnose correctly, then treat properly. So this is my last slide. Take home messages. Chronic kidney disease is obviously overdiagnosed, but most of the clinicians won't take EGFR alone. There should be a rise in serum creatinine, at least above 1.2 according to current assay methods, or there should be evidence of kidney damage like proteinuria or microscopic hematuria or ultrasonic evidence, so on and so forth. Then clinicians should be skeptical about CKD diagnosis in marginal cases, especially in elderly, and look for evidence of kidney damage to support the diagnosis of CKD, and liaise with nephrology services if in doubt, and never label a patient with CKD until conclusively done, and individualize CKD treatment and don't overtreat. So with that, I would like to invite you for World Kidney Day celebrations at Badulla. We will be having a public walk and speech, and if you happen to be doing any sessions of this or something else at Badulla, please come and join us on 4th April at Provincial General Hospital, Badulla. Thank you very much.
Yes, thank you very much, Dr. Udana Ratnapal, for that very interesting. Was the last, but said it was very interesting talk, and now it kept us, it kept us alert, right? So I now it's open for discussion. Any questions? Any suggestions? Any views? Any points of view? Yes.
No, actually the recommendation does not say there is a replacement of this dose of people. As Dr. said, in certain situations we need to reduce the dose. Only recommendation is that if the patient is severe case, we can prolong the course of treatment. Generally, it is recommended for 5 days, certainly, but if the severe case, we can prolong the course, but not double. Unfortunately, some still use that.
Do we have early preparation in Sri Lanka?
Not to my knowledge.
Now, if a young person comes in the personal epidemic like now, with symptoms of influenza, it's not essential to do the influenza test specific.
No, sir. Actually, it is not essential to do either the testing or to give treatment.
Yes.
Patients, it's a common thing. It's several of its own. These patients need testing and treatment for the cough and the fever.
And they can be managed at home. It's simple analgesics and bed rest and fluids. Yes.
Yeah, these are common practice on the private sector to ask the influenza. Very expensive test as well.
And I'm sure people very soon will end up with something resistance.
Yes.
The rate is being given. Yes.
But then once you decide to give this drug and flu, and within 24 hours you see an improvement also. That's my experience.
There's improvement, but again I think it varies from individual to individual. Because some patients come with typical symptoms, which sometimes with a positive report also. They said they felt very bad yesterday and today they are feeling better. So for such patients, I don't start treatment even though even they come with a positive report.
This is the re-toxic doctors also need facility. No vigilance needs to be, because I've worked during last 1 year Inkomali, Markara and Badulla in all 3 areas, but I have come across yourself induced strep toxicity and in all three parts of the country.
Yeah, that is very important, especially
Yes,
when
yes,
we
very
get
important.
serious situations. And just one more thing, I think it is too much of emphasis is put on the testing, treatment as well as vaccination when it comes to
Is there a difference when you do serious getting fasting and non-fasting state?
Yes, there will be because
Yes.
creatine tends to get influenced by, of course, muscle mass, amount of water in your body. So fasting sample is not ideal to do a creatinine. So creatinine should be done after 3 days of rest. Is ideal setup, right? We can't do this in the day-to-day practice. 3 days of normal, not aggressive exercise, normal kind of day-to-day work. And of course, ample amount of water, 2.5 to 3 liters according to your thirst, and then you should do the creatinine.
Yeah, we find this as a practical when you are doing CT scan. But now we are using prescriptions, fasting blood sugar, serum creatinine, everything one prescription.
Yeah.
So they come fasting in the lab. And they do both fasting sugar and creatinine, and we get a upper limit.
I see the creatinine, you can't go
Very trouble.
easy. Yeah.
And to come again.
Yes. So in ideal setup, you should do fasting serum
Yeah,
creatinine.
the laboratories was advised.
That's true. And once again, there are two methods of peak serum creatinine. That's a problem in country also. So the FA method gives a high value, 0.3 times higher, and enzymatic method gives a low value. So private sector, private sector is enzymatic, and most of the government hospitals do FA. So there is a difference between creatinine done from different laboratories also. So once again, if you pick a laboratory, if it's correct, you have to stick to that laboratory and do serum creatinine in that particular kind of laboratory. Otherwise, it's very difficult to introduce the API or formulation.
the enzymatic will be better.
Enzymatic is better, but in the government sector, still we don't have enzymatic.
May I ask Dr. Abrasena, now in a patient who comes with typical angina on exertion, with a normal resting ECG, you say there is no place for exercise ECG. With a normal resting ECG, classical angina on exertion.
ECG will be abnormal if the patient has got a function of either lungs or the it is a normal ECG. But the symptoms are what matters. If a person has certain adventure symptoms, because pressure or symptoms also, more than just when they have walking, they have a sample to go to the door. Of it's failure or something. That's what you call the typical symptoms. I don't think you need anything else. Because the CG will be abnormal if you want to impact, but you don't want them to impact.
Before that.
So there is no place for doing exercise ECG, and if that is also normal.
It's very dangerous.
No, if the normal this thing and
You may have a normal ECG, but supposing you got a reference stenosis, which is what is causing the symptoms. You might be having hepatitis, everything, osteal development, stenosis, and nothing else. And when you come to that point, then your medical symptoms, you might put them on the medicine and go to the reference, and you will update and you never recover. So the thing is a problem. So classical symptoms, you should not ask for treatments. Treatments are dangerous.
So in what indication would you ask for a treadmill then?
The thing is, you have a lot of, atypical symptoms, and also patients are coming with atypical symptoms. And you say, not the classical symptoms. I'm talking about atypical symptoms. Other people come with the left side and chest pain, like that. They can walk, but then they say they will give this and they're lying down there. And everybody's scared because of all these various other things like family history and they have best friend doctor 2 weeks ago, things like that. Now, that kind of situation you can do it. But don't do it in classical cases, particularly where patient is actually, supposing he gets chest pain and he goes times or something like that, they're not going to give it. Because it's, he has done that amount of it. But if he is going and getting a treadmill, and is just discomfort, and he is just walking towards the bus stand or something, which he has been doing all along. And then suddenly these things have changed. Then you are taking a risk.
Then you will proceed to angiograms then. You may, yeah. Yeah.
Those cases,
Now when studies are done between the CT angiograms and the normal angiograms,
the normal angiogram is the gold standard.
it's a gold standard, no?
You
Yeah.
can't
You can't compare the two.
Yes.
What you are really doing is even if you can, there are a category of patients who can, you can avoid the invasive normal angiogram, the conventional angiogram. There are, as I mentioned, there are a lot of people who are pretty well, no, we don't really have nothing can do with these publicists because they are not on problem. Sometimes you might think that the angiogram is an option in that category, but certainly you can't compare them with the normal angiogram.
So there are some questions from the audience who are watching this on the webinar, and I think it's for you, Dr. Alayyar. It was not controversial, I suppose. About CKD. So the question remains: when should we refer an individual found with high creatinine?
Good question. Once again, we don't have criteria in this country, but in other countries it's CKD stage 3 and below. So if the EGFR, once again, though it's, we don't like it, we have to go by it. If the EGFR is less than 60, we have to refer to a nephrologist to see whether, first of all, to see whether these component of, whether there is acute component is there, whether there is any possibility to revert it. Second thing, to prevent progression. Third thing, if the cause is not found, if the cause is not clear, to do a biopsy and immunological screening and to come up to a etiological diagnosis. For these three reasons, in other countries, they like the patients to be referred at EGFR of 60. But Sri Lankan situation, I am not sure whether we can take all these patients below EGFR 60 to our nephrology kind of workup, because we have got only 22 nephrologists in the country so far, and with the workload we have got, and especially the areas I work with, the amount of CKDVC, for example, Badulla, we have to do screening. It is against, because every other patient is having high serum creatinine, and if I want to pick up a donor of your family, say for example I have an end-stage patient, I ask the mother or the brother to get a creatinine and to get it done, to do what we call to do the donor workup. Invariably they have high serum creatinine, especially the patients from Mahiyangana, Monragala. There's a huge population of CKD, and the other place I worked in Trincomalee and all, there's a huge problem. But in Colombo, I think you all are safe, and Matra also, things are relatively safe. The reasons I don't know, but the prevalence is exceptionally high in those areas, affected areas, by so-called CKDU. So still, it would be CKD stage 3 and below, EGFR of 60.
So can I ask a few questions, because as a general practitioner, I am a little bit confused. Really confused. Before I came here, I had some form of clarity, but I am really confused because you confused me. Because you said protein restriction is not needed. I mean, we send patients who are really maybe EGFR 55, 60, that kind of thing, and we get the complete opposite advice. Sorry to tell you, but
from the nephrologist.
General physician, but nephrologist.
That's true,
Second thing, Dr. Yavikrama, patient come and tell us, Doctor, I had 2 children, they are grown up women. Now you say that it is not necessary, right? And how can we end? I was asking Dr. Amarasena, is it good to give a present of, now they have various packages here in the Katahari, especially the ladies. You have your husband around 50, give a package with a CP partner for the next birthday of your
Good question. Yeah, okay. Okay. Yeah. First of all, yeah, regarding my question, whether we should, do a, yeah. I think.
You are coming and telling protein who are we to believe? Are you a special kind of Christians or?
Yeah. So I think Professor Kumar is trying to, make a conflict between myself and my teachers. So I would say this is kind of, I don't know, this may be a generation gap. But whatever it is, it's very clear in the 2013 guidelines and there is evidence. Of course, when you compare patients from UK or other countries, we have visited China and so on and so forth. The CKD patients, they have got muscle mass and they can withstand dialysis or they can withstand transplant. But here it's very difficult for our patients to withstand dialysis. You will see our usual life expectancy on dialysis is less than 1 year. So most of the patients, and we don't do 3 times a week. One reason, and our what we call renal dietary advisors are entirely wrong. And once again, it's the famous MCQ for MRCP nephrology. One important question is what is the leading cause of mortality in dialysis populations? 1, hyperkalemia, 2, fluid overload, 3, myocardial infarction, so on and so forth. But the answer is malnutrition. So you see the amount of malnutrition and the problems caused by malnutrition. So the pendulum has changed maybe from 2015. Now we are planning to give adequate nutrition and we need to individualize nutrition. Not so. Once again, when I came to National Hospital after completing my foreign training, the dietitians and all came to me and asked for a leaflet for all the patients on dialysis, all the patients from CKD stage 3, CKD stage 4, so on and so forth. But you can't give a leaflet for any patients. That cannot be practiced because this may be a CKD potassium wasting. Potassium may be 3.2, 3.3. This may be a case of polyuria and sodium wasting. Then you have to keep a normal salt diet. So, it should be individualized. So, until we get renal nutritionists or renal dietitians or nephrologists getting trained in renal nutrition, there will be a problem in this practice. And, I have a huge problem with my colleagues also, my advice is quite different from my senior colleagues' advices. So, usually, but patients do like to hear not to eat rather than to eat. So, they like it. Probably this is a tip for private practice. So my private practice may be low. We'll see in the future. But people like to hear not to eat rather than to eat. So this. Yes.
And almost farmers are already thin.
Yeah. They don't have
North Central farmers. They're already thin. They're already wasted.
Yeah.
So when you put them on low protein diet, it just aggravates the problem. And
yes. Yeah.
And then the moment the creatinine goes up slightly, somebody will go and take that metformin.
Yeah, that's true. Yes. Yes, correct. So that's why I have to give a lecture. Yeah. On myths and facts on CKD. So these are all myths. You should continue metformin as far as possible until EGFR of 30. That means CKD stage just before CKD stage 4. Even early CKD stage 4, metformin is that important to prevent cardiovascular mortality. So metformin is a myth again. And of course, non-steroids. There is a myth again that some non-steroids are safe. Once again, Sulintec, it is notorious among physicians to be prescribed for CKD, but it's proven, point blank that no non-steroid is safe, and you should minimize the use of non-steroids. There are a lot of myths in CKD. So no, we might have to put some effort to change the practice. Yeah.
But patients were already very thin.
That's correct. Yeah.
Something useful change, something like glycoside, because metformin will also promote weight loss.
But madam, metformin is needed for cardiovascular disease prevention. So that's what, CKD people die of myocardial infarction, not from end-stage renal failure. Most of them before reaching end-stage, that's it. So it's all cardiorenal. So metformin is a must in most of the patients, even in people.
I don't know how this will change. Patients and they will come and ask, Doctor,
yeah.
So that is a very, very common.
That's true. Yeah. No, it's Yeah, that's what. So we have this problem. That's
the other thing, when the T level goes up, the doctor himself withdraws metformin. That further strengthens that idea metformin causes the renal disease. Unless you explain it to them, they will carry the message.
So we recently did a GP session, myself and my endocrinologist at Mathura. We conducted a combined session on diabetic kidney disease, and clear-cut advice from endocrinologist was you can stop metformin when EGFR comes down to 30, but inform the patient this is not because of nephrotoxicity of metformin. This is because we can't give this drug when the kidneys this is not due to. So whenever you stop metformin, you have to tell the patient that metformin is very important, but you can't give this important drug now since the kidney has gone on its own to EGFR of 30. Now, if you don't tell that to the public community, it's a difficult myth to come.
I always ask the patient, has anyone told you anything in your staff office or anywhere? Invariably they say yes. And then explain to them that is not so. And I go to the extent in that case, why don't patients go to courts against the doctor for prescribing metformin? There are no answer to that. Yeah.
My other confusion.
I think I'm not a better because I'm not going to conflict with my teachers. My boss is chairing the session, so problem. So actually, now most of these patients will have high fever, and similarly, a lot of other conditions. Similarly, the same anxiety is there in patients with dengue, especially when dengue is diagnosed. So just the high fever is not a criterion for admission and not a criterion for start oseltamivir. It is the respiratory severity of the respiratory symptoms and signs is the no rather than symptoms, the signs. Whether they are becoming hypoxic, whether they are becoming dyspneic, and whether their respiratory rate is increasing. Those are the criterion on which we have to base our decision on starting oseltamivir. Otherwise, one thing is expensive, and there's no use on other patients starting, then will not give rise to any benefit.
Where do we get from
Somebody and where do we go from here?
So I think that's the question I pose for the audience. One clear, the next stop will be the SLMA session. Madam has already agreed to have a symposium, overdiagnosis of cancer. I think it's on the table, on the agenda, and at least two people from the BMJ. I just was reading the email from the Indian editor of the BMJ, who wrote two nice articles on the overdiagnosis. She has agreed to come, and the doctor in Australia, Sri Lankan doctor, Dr. Tanya Patiran, she has agreed to come and address the thing. That is one thing. But I think these are all theoretical 1 to 2 hour limited stuff. How can we move this message to our doctors and the general public? I mean, we are very happy to have this session and then go away.
Encouraged by most private hospitals and private consultations. Yeah. So those who have funds, especially an insurance, so they will get overdiagnosed and overtreated. So the SLMA should sort of collaborate with the College of GPs and have some guidelines.
Can we have something like choosing by
Yeah, to have guidelines, because you have to have a feedback for the public. Yeah, the public.
Unfortunately, when angiography is done on a several times, and when it is all clear, the young man is very happy. It has been done, and I am clear. These are
Yeah.
we are happy that it was normal. It was normal. When I say, if you came to me first, I would have told you the same thing without all this.
But you were giving him a DVD, no? Will they believe you without
That's why you're laughing at me. I see no light.
Yeah.
And you won't give him a DVD. You won't give him a DVD.
And the other thing is these packages for screening. They come from the private companies, all of them say they are here. I'm sure they are being promoted by the private companies.
Yeah.
And they are a young man getting ultrasound.
So actually it is catered for the people with insurances, but unfortunately even the poor man get carried away.
So can we at least ask the CNG editor to have some form of at least, no, at least. Yes, because at least, no, even this whole thing will be released to the YouTube. We have recorded the session, but at a national level, we have to do something. Okay, thank you very much.
Anyone want to come who are not already members?